endometrial changes to make it more receptive and preventing the implantation. Once the ovulation has happened and fertilization has happened, the corpus luteum is stimulated by the SCG which is being produced by the syncytial cycloprophlast, which is the source of SCG. And this SCG is acting on corpus luteum and continues to produce progesterone. So progesterone is a very important thing in all this affair of fertilization, post-fertilization, implantation. And progesterone secretion by corpus luteum is required because it supports the endometrial growth, it improves the blood flow and oxygen supply by increasing the nitric oxide, it keeps the myometrial quiet and relax the uterus, and it sustains the survival of embryo by shifting the immune system to T2 response, which is helping the pregnancy to continue. Luteal phase support. There is no treatment for luteal phase support has been shown to improve pregnancy outcome in a natural and unstimulated cycle. Please remember these two, natural and unstimulated cycle. There is no need for luteal phase support. In ART cycle, you can give either progesterone or SCG, but SCG increases the risk of OHSS. And there is no proven role of adding progesterone or SCG for luteal support once the pregnancy has been established. Once pregnancy has been established, there is no need to give any progesterone or SCG. And supplementation of progesterone in non-ART cycle, that is IVF cycle, beyond the time of expected menses or 2 weeks after ovulation, is also not proven benefit. So you don't have to continue progesterone for a longer time in an IVF cycle. Full required luteal phase support, ART cycles, and unexplained infertility, advanced infertility age, hyperprolactinemia, and recurrent pregnancy loss. What is the rationale for luteal phase support in assisted reproduction? The low progesterone environment which is created iatrogenically. How it is created iatrogenically? There is a abnormal corpus luteum function showing following the video stimulation and abnormally raised progesterone level during the early luteal phase coincide with premature leukolysis. How it happens? Basically, the supraphysical steroid level by multifollicular development during IVF inhibit the LH secretion from pituitary, and this low level of LH causes leukolysis, implantation failure, and shortened luteal phase. What are the other factors in IVF cycle? The depletion of granular cells due to follicular aspiration. When we are aspirating the follicle, we are also depleting the granular cell, and that is causing granular cell is the seat of progesterone production. There is low progesterone. And leukolytic effect of antagonist, which we are using, antagonist is the protocol most commonly used, so that is also having leukolytic effect. And strong negative feedback on pituitary by the supraphysical steroid I already mentioned. And low LH level causes leukolysis, implantation failure, and shortened luteal phase. Thyroid and prolactin disorder can also cause GnRH, can disrupt the GnRH excretion. What is the luteal phase defect? It is a failure of lutein lining to be in the right phase at the right time. Very short definition. Right phase at the right time. That endometrium has to be right phase at the right time. That can be because of inadequate progesterone production by corpus luteum, or the inadequate response of the endometrium to the progesterone which is produced by corpus luteum. It can be either one of the two things. And what causes the luteal phase defect? There are four main causes. If you look at it, it can be either poor follicle production, it can be defective corpus luteum, it can be premature failure of corpus luteum, or it can be failure of uterine lining to respond to this progesterone which is produced by corpus luteum. Either of these can be the cause of this luteal phase defect. And what is the prevalence? 5 to 10% of pregnant women have luteal phase defect. 25 to 40% of recurrent pregnancy loss have luteal phase defect. 50 to 20% of women in unexplained infertility have luteal phase defect. How do you diagnose in a natural cycle? Either there is a shortened luteal phase. The luteal phase is less than 10 days. Normally it is 11 to 17 days. Or there is a blunted rise of basal body temperature, or discordant or short luteal phase defect. Or there can be decreased low mid luteal serum progesterone, or out of phase endometrium, or inadequate strictly changes in endometrium and luteal phase. These are all the general markers which can help us diagnosing luteal phase defect in a natural cycle. But how to define this? As per this criteria, the serum progesterone, if it is less than 10 nanogram in the mid cycle, we say there is a luteal phase defect. Or if there is a lag of 2 days in the endometrium biopsy, we say it is a luteal phase defect. These are all older criteria. But when we see it, the diagnostic criteria prove to be imperfect. So now we are shifting to molecular biomarkers. We are trying to shift to molecular biomarkers for evaluation of adequate progesterone administration on the endometrium. These are the molecular biomarkers which we are going to use more frequently in the future. That is the twin coil formation in the endometrium, integrin expression, immunomodulator transformation, and pre-receptor gene expression. The genetic thing is going to come up in future. That is how we are going to diagnose luteal phase defect. Detecting luteal phase insufficiency, like I mentioned, the mid-luteal progesterone has to be 10 nanogram, and endometrial biopsy is no longer the gold standard for assessment. Now we have come to the stage when endometrial biopsy is no longer the gold standard. The out of phase by 2 days is no more relevant. So there is no consensus on the minimum serum progesterone concentration that can define